Chronic Exertional Compartment Syndrome has been defined as a condition where abnormally elevated intramuscular pressure induced by exercise impedes local blood flow and impairs neuromuscular tissue function. The condition is most prevalent in young adult athletes and military personnel, with an incidence ranging between 27 to 33% of all chronic lower limb pain presentations, second only to medial tibial stress syndrome. Before we dive in, let's do a quick refresher on the anatomy of the lower leg, which comprises of 4 compartments separated by inelastic fascial sheaths. The superficial posterior compartment contains soleus, plantaris, both heads of gastrocnemius, and the sural nerve. The deep posterior compartment comprises deep flexors and popliteus, as well as the posterior tibial artery and vein. The lateral compartment contains peroneus longus and brevis, and the superficial branch of the common peroneal nerve. And the anterior compartment contains tibialis anterior, the deep extensors, and peroneus tertius, as well as the anterior tibial artery and vein and the deep branch of the common peroneal nerve. Some argue that tibialis posterior lies in its own 5th compartment. There is currently no consensus regarding the pathobiological mechanisms behind this condition. However, several plausible theories exist, and it's believed to be likely multifactorial in nature. Abnormal venous outflow, decreased capillary density, abnormal fascia, and rapid muscle hypertrophy in the setting of overtraining have all been suggested. Repetitive overuse, especially with abnormal biomechanics, can lead to fibrosis and fascial thickening and therefore non-compliance, where the collagen tissue responds to overuse and prolonged stretch by aligning its fibers to increase its density and strength. During strenuous exercise, muscle volume increases up to 20% in the setting of increased blood flow and edema. When this occurs in combination with fascial inelasticity, pressure in that muscle compartment increases well above normal physiological levels, and venous drainage becomes impaired. Subsequently, the arteriovenous perfusion gradient becomes too narrow, causing fluid to accumulate in the interstitial spaces and arterial inflow to be impeded. As tissue perfusion decreases, ischemia develops in the setting of hypoxemia, and lactate is produced in addition to the activation of stretch receptors in the fascia. This is thought to be the pathobiological mechanism behind this condition and the pain experienced during activities. However, further research is still required in this field, as literature has yet to reach a consensus on this topic.